Hello, I'm Ulrika Wolf, a clinical hypnotherapist and strategic psychotherapist. In this briefing, I want to explain what I mean by a process-focused approach, why understanding a problem is not always the same as changing it, and how therapy may examine the patterns of attention, interpretation, and response that keep a difficulty alive. People often come to therapy with a very clear understanding of what they're experiencing, that they know when the problem began, that they know what triggers it, that they may understand where it came from and how it affects their work, relationships, confidence, sleep, or daily functioning. And yet, even with all of that insight, the same sequence can continue, and that can be incredibly frustrating. A person may start to believe that they lack discipline, motivation, or self-awareness, when in reality, they may already understand the problem very well. The difficulty is that insight into the history or content of a problem does not always change what happens in the moment the problem becomes active. That is where a process-focused approach becomes useful. The content of a problem is what it appears to be about. It might be a fear of public speaking, difficulty sleeping, overthinking, a habit the person wants to stop, distress after a relationship ending, or worry about health, performance, or uncertainty. The process is what happens around that difficulty. Where does the person's attention go? What do they predict? What meaning do they assign to this situation? What do they then do internally or behaviorally? What short-term effect does that response have? And how might it contribute to the pattern continuing? A process-focused approach does not dismiss the person's history, emotions, or circumstances. It adds another layer of inquiry. Not only what happened, but also what is happening now. A maintaining process is not necessarily the cause of a problem. It's also not evidence that the person is choosing to remain distressed. Many maintaining responses are understandable. They may have developed to create safety, certainty, relief, control, or emotional distance. For example, a person may repeatedly check something because uncertainty feels intolerable. They may avoid a situation because the immediate reduction in distress feels protective. They may over-prepare because mistakes once carried a high cost. They may ruminate because they believe that if they think long enough, they will eventually find certainty. The difficulty is that a strategy that helps in the short term may become costly over time. Checking may briefly reduce uncertainty, but increase the urge to check again. Avoidance may reduce distress, but prevent the person from discovering what they can tolerate. And over-preparation may create a sense of control, but make spontaneous action feel increasingly unsafe. Rumination may feel like problem-solving, while repeatedly returning the person to the same unresolved position. The therapeutic question is not simply whether the response is good or bad, but rather is it helpful to the client in the context required. Attention is selective. At any given moment, more information is available than we can consciously process. What we repeatedly attend to can become psychologically prominent. For example, a person preparing to speak in a meeting may monitor their heart rate, voice, facial expressions, and signs that others are judging them. The more they monitor, the more noticeable every sensation becomes. Their attention moves away from the actual task and towards internal evidence that something may be going wrong. This does not mean attention creates every symptom. It does not mean genuine danger or medical concerns should be ignored. It can mean that the direction of attention can influence which information is amplified and which information is missed. A process-focused approach may therefore ask, is the person attending to useful information? Are they monitoring in a way that supports action? Or is attention repeatedly confirming a feared prediction? The same experience can carry different meanings. An increased heart rate may be interpreted as ordinary activation, or it may be interpreted as panic, danger, failure, or loss of control. A delayed reply may mean the other person is busy, or it may be interpreted as rejection, conflict, or evidence that something has gone wrong. The meaning assigned to an event influences what happens next. If a prediction is treated as a fact, the person may begin responding to an outcome that has not actually occurred. And therapy does not simply replace negative thoughts with positive ones. It may instead help the person examine what has been observed directly. What's being inferred? Is this possible, probable, or certain? What happens when this interpretation is treated as a fact? Does the response help? Is there another interpretation or action that is both credible and more workable? An important part of my work is helping clients or your patients build clearer distinctions. For example, a thought is not always an observable event. A prediction is not the same as an outcome. Discomfort is not always danger, possibility is not probability, and emotion is not necessarily an instruction to act. Reflection is not the same as rumination, preparation is not the same as checking, protection is not always the same as avoidance, and what provides immediate relief may not always support longer-term functioning. These distinctions are not imposed mechanically. A thought may be accurate. A fear may reflect a genuine risk. Avoidance may sometimes be protective. The purpose is to help the person respond with greater precision, not to explain away legitimate experience. Two people may both describe themselves as overthinkers, but the process may be very different. One may be trying to prevent mistakes, another may be searching for complete certainty before acting, another may be replaying a social interaction, another may use analysis to avoid experiencing grief, anger, or vulnerability. The symptom label is the same. The therapeutic strategy may not be. This is why process-focused work relies on individual formulation rather than assuming that one explanation or intervention applies to everyone with the same complaint. A process-focused approach usually begins with assessment. I want to understand what the person wants help with, what happens when the difficulty becomes active, where attention goes, what they predict, how they interpret the experience, what they do in response, what immediate relief or consequence follows, what has already been tried, and what broader medical, psychological, psychiatric, or social factors need to be considered. From there, we may develop a provisional formulation. That formulation is not presented as a fixed truth, it is a working hypothesis. It should make sense to the client, remain open to revision, and change when new information appears. Treatment or progress plans may then involve focused questioning, behavioral experiments, attentional exercises, guided rehearsals, skills practice, clinical hypnosis, agreed work between sessions, and things like that. The intervention should serve a clear therapeutic purpose. Clinical hypnosis may be incorporated where it supports the broader strategy. It may be used to support focused attention, mental rehearsal, guided imagery, experiential learning, or practice responding differently while discomfort or activation is present. For example, a patient or a client may understand that physical activation during public speaking is not necessarily danger, but in the moment, they may still monitor every sensation and interpret it as proof that they're failing. Hypnosis may be used to rehearse directing attention towards the audience, allowing some activation to remain present, slowing the response and recovering from an imperfect moment. The hypnosis serves the strategy. It's not independently removing the problem. It's also not used as a standardized script, standalone approach, or replacement for indicated medical, psychiatric, or psychological care. A process-focused approach may be appropriate where a client has an identifiable goal or recurring response pattern and may benefit from an active, skills-focused, and experiential form of therapy. A formal referral is not generally required for private appointments. However, a referral letter can be valuable where there's relevant medical or psychiatric history, current medication, diagnostic uncertainty, risk, or an existing treatment plan. Clients should remain under the care of their GP, specialist, psychologist, or psychiatrist, where ongoing diagnosis, medication management, medical investigation, or specialist mental health care is required. Suitability is always assessed individually. A process-focused approach asks a practical question. What is this person repeatedly noticing, predicting, interpreting, avoiding, or rehearsing that may be keeping the difficulty alive? And what different response could be understood, tested, and practiced? That question does not replace the person's history, diagnosis, emotions, relationships, culture, or circumstances. It helps organize therapy around what may be changeable in the present. Thank you for taking the time to learn more about a process-focused approach. You can read the full briefing on the online hypnotherapist Clinical Briefings Hub.
The Clinical Briefings Hub is a free, dedicated professional resource for GPs, specialists, and allied health practitioners who would like more detailed information about clinical hypnotherapy, strategic psychotherapy, and referral considerations. The Clinical Briefings Hub is a separate space that allows you to explore the complete evidence-informed briefings behind the information on the main website. When you open a briefing, you will see the estimated reading time at the top so you can decide whether to read it now or later. Each briefing also includes call-out summaries that highlight important clinical points and practical information for quick review. The content is divided into clear sections, allowing you to move to the information that is most relevant to you. You can also expand or collapse sections as needed and skip to the sections that are of most interest. You can also review the supporting sources in the footnotes and click directly through to available research, professional guidance, and further reading. The complete briefings include all three collections, foundations, clinical presentations, and the referral process. And you can see there's far more here as well for you to access. Health practitioners can freely access the clinical briefings by subscribing to the Online Hypnotherapist Professional Updates.